Hello, happy Thanksgiving Eve to all of you. We are here with another live edition of I Care for Your Brain with Dr. Karen Sullivan, board certified neuropsychologist. We have been here for 2 years, every Wednesday offering you free brain health lectures that hopefully educate you and empower you, all of you out there living with a brain health challenge. We are very close to 6,000 other brain health learners, 6,000 followers. And if you enjoy watching the show, I would really appreciate if you would suggest the page to other people. The more people we get to follow us here, the more power we have to get out there in the world and take this to the next level. So tonight's topic was sent in by someone who follows us. She had a very good friend who had a bout with vestibular neuritis. And so I know some about it before tonight, but I decided that I would do a nice little research project, research it, and report back to all of you what I found out. It is also known by the very mystical name of labyrinthitis, which sounds like something out of a some kind of a novel from New Zealand or something like that. There are many conditions that result in some of the symptoms that we see in vestibular neuritis. The number one symptom is vertigo. Vertigo is horrible if you've ever had it. It is the feeling that you or your immediate environment is moving, spinning. There are two kinds of vertigo. You can have subjective vertigo, which is when you feel as if you yourself are moving, or you can have objective vertigo, which you feel like your surroundings are moving. Vestibular neuritis is the second most common reason people get vertigo, and about 7% of people at the outpatient clinics to get treated for vertigo wind up having vestibular neuritis. VN, as they call it, can be either stable, meaning it comes and it stays that way. It can be progressive, meaning it actually gets worse over time, or it can fluctuate, which means it comes and it goes. So a stable vestibular disorder is something like vestibular neuritis, where for many people it doesn't stay at the same level, but there is a relative stability of symptoms over a long period of time, which is one of the myths I want to talk about tonight. If you Google VN, you're going to see a lot of research, a lot of feedback that basically says it should go away in about a month. It comes on really quick, which is true, but it goes away in a few days. And when I looked at the scientific literature on VN, oh my goodness, there's a big difference between if you are a Google searcher versus if you know the search engines to go to that will give you science-based information. They're literally worlds apart. So that's one thing I want to talk with you about tonight. A progressive vestibular disorder would be something like multiple sclerosis, progressive muscular sclerosis. A fluctuating condition would be something like migraine, Meniere's disease, relapsing remitting MS, symptoms that really come and go. So the vestibular system is what we're talking about here. This is basically a sensory system that's located in the inner ear, and this tells our brain where we are in space. When we are moving and space is moving, how are those two things related? So this has something to do, of course, with our sense of balance, our ability to maintain our posture, our ability to stabilize our head and our body during movement. These are often things that we take for granted when our brain is working very well. If you have had a brainstem injury, if you have a pons injury, if you have a cerebellar injury, or if you have an injury to your vestibular system, you know that just feeling balanced and feeling stable on your feet and in your own body is a very, very, very big challenge. The symptoms of vestibular neuritis are sudden. This is a key thing. They usually come on within minutes to hours, which can be very challenging because this means all of a sudden you could be going about your day and next thing you know you have severe spinning, you feel like you're swaying back and forth, you're extremely dizzy. It can also come on over the course of just a few hours. Most people have significant balance problems with VN. And how we judge that clinically is something called the Romberg sign. So one of the things we do as clinical doctors is we can ask someone to close their eyes, and we just move them a little bit. We might push them forward or backward. And basically, without the visual system giving them feedback, they often fall towards the affected ear. So let's see you have the vestibular issue in your right ear. If we have you close your eyes and we push you a little bit, we're going to know that that's the ear that's affected because you fall to that side. We also know that if we look at your eye patterns, we call it a nystagmus, different ways that the eyes can move back and forth in coordination, that the eyes actually tend to move to the unaffected ear. So these are little clinical things that we look for. It can also be associated with nausea and vomiting, of course, because you just feel so imbalanced, your equilibrium is just completely off. This is very interesting. The change that has happened over time in understanding why people get VN is very unique. So in the past, it was considered to be an inflammatory issue of the vestibular nerve or poor blood flow to the vestibular nerve that was resulting in ischemia. But in the last 10 to 15 years, we now think it's more of a viral situation that is causing it. So most cases of vestibular neuritis are caused by a viral infection either in the inner ear or another part of the body. So the most common reasons are things like flu, measles, mono, mumps, shingles, and chickenpox. For a long time, it was also thought that the herpes simplex virus also involved, but that's gone a little bit out of favor. One of the reasons why we used to think that is because the medicines that worked for other conditions that were caused by the herpes virus, namely Bell's palsy, thought to be an inflammation of a facial nerve, very similar to vestibular neuritis, just in another way, responded very well to herpes simplex drugs. So we kind of made this distinction, but there have been some really well-designed studies that have basically shown the medicine, if you just give it when someone has VN, aren't necessarily that effective. So it's relatively common, right? It can certainly diminish people's quality of life, their mood, and other aspects of their physical wellness. A big thing that I see as a neuropsychologist is how it affects mood. So how would you feel if all of a sudden you did not feel at home in your own body, you felt like the world was spinning, you were at risk for falling? Chances are you would probably become pretty anxious. Now, what's interesting about that is that we have been growing in our understanding of traumas and allowing ourselves to validate that traumas aren't just things that happen in the military, they're not just things that happen as a result of interpersonal violence, that very oftentimes things in the medical world that happen to us are very traumatizing. So the definition of a trauma is that it is a sudden, unexpected change that makes us feel helpless, that makes us feel like things are out of control. So I'm not suggesting that vestibular neuritis can give you post-traumatic stress disorder, but we know human emotions happen on a spectrum. So there is some evidence that it can be so stressful to someone to have these symptoms that they can start to do things that they think are making them better, like avoiding any potential triggers, to the point where they're actually making it worse in the long term because they make themselves so hypersensitive. We're going to talk about that a little bit later. People can also, of course, get depression. There's a very interesting distinction between when the objective tests suggest to your doctor that the inflammation is over and you should be asymptomatic, versus when you actually talk to patients. Many more people are reporting ongoing symptoms. It's just that the objective test that we know how to do at this point in brain science is not matching up. So I think oftentimes not very sophisticated or sensitive doctors are probably giving people the feedback basically like, there must be something else, it must be in your head, it must be pure anxiety alone, because we're not seeing it on the specific test that we do. So we got to talk about that for sure. If someone tells you, an expert, a doctor tells you this shouldn't be happening, then you're probably not going to get any treatment, because if they don't think there's anything wrong, you're not going to get a referral to go and do the therapy that might necessarily make you better. So one of the things that we do very normally when we fear something, perhaps like symptoms of vestibular neuritis, is we become very hypervigilant. What this means, it's basically old school primal defense mechanism where we like to think that if we could just pay close enough attention, we could figure this thing out and figure out the first cause or the reason that something happens. So when something is going on in your body, any of you who have had a stroke know this, is you start to become an expert scanner in what is going on in your body. And oftentimes you actually make it worse because you don't know how to interpret normal dizziness. You know, if I got up really quick, my blood pressure is going to struggle a little bit to adjust in a very short amount of time, and I'm going to have some being a little bit dizzy. But if I come to that symptom with someone who's been traumatized by unexpected dizziness that is horrible and makes me feel totally out of it and not safe and out of control, I'm going to respond differently to that symptom, right? So what people do in response to that many times with VN that doesn't go away is they basically become very sedentary and try not to do anything that's going to set off the symptom. So they try not to move their head too quick. They try, you know, depending on where the symptom started, maybe there's an association there with being on the certain couch or being in bed. So over time, you can actually see that people's physical wellness goes down from VM because they just become more sedentary. So they lose stamina, the muscle strength gets bad, they lose flexibility, they have more joint stiffness, and we call this debility overall. And so it basically means you just get out of shape really, really quick because you're not really doing much. So that, of course, just creates a vicious cycle because then when you actually go to do something, you're going to get more feedback from your vestibular system, and now you're hypersensitive to it. So it just can really create this downward spiral. This is very similar to what we see happening in any type of phobic anxiety, is that slowly but surely we start to avoid the things that we think are going to set it off, but over time we're actually training our brain to become more intolerant of any type of movement. So again, you think you're helping yourself, but ultimately you're kind of making your world smaller and you're making yourself more sensitive. So the same exact way we treat something like a panic attack is one of the ways we start to think about things like VN. And so we use a process of systematic desensitization. So we're going to talk about that as we get more into treatment. But the idea is that you really need to take VN very serious when you know that you are retreating from life and it's starting to affect your quality of life, your mood, your relationships, your function. So remember before I said recovery is kind of controversial. If you just did a Google search and you've had VN for 3 months, you're going to feel pretty bad because the very first thing that popped up in my search was that it usually improves in a few days, and some symptoms can take about 3 weeks to subside. Okay, well, if you start to look at the scientific studies, holy smokes, there is a big, big, big difference. So if I go over to Google Scholar, and these are free, readily available, PDFs from scientific literature, which I encourage all of you to pursue, I found several studies that talked about that 43 to 53% of patients still feel that they have episodic vertigo or unsteadiness. There was one study in 1993 that over 90% of patients after 1 month still felt like they had symptoms, and after 6 months, 80% of people with VN still felt that they were having symptoms. And so going into this and doing the research, the main difference seems to be the difference between formal test results and subjective symptoms, which is in essence how you feel, what you tell your doctor you feel. So this is a problem because we've got these laboratory tests, caloric testing. Maybe some of you have had it where they put the cold and the hot water in your ear. There's different maneuvers they can do with your body. And if you don't respond a certain way, the doctor perceives that the VN has resolved. The inflammation in your vestibular nerve has gone away. However, many of those exact same patients will tell you if you ask them, no, my eyesight is still weird. I still feel like I'm going to fall over when I'm walking. My head movements especially feel like I'm very, very dizzy at times. And that's a problem in clinical medicine because we never ever want to invalidate real symptoms that are happening to people. So one of the questions in the literature has been, well, is there anything unique about these people, the 80%, let's say, that go on to continue having symptoms? Is there anything unique about them as a patient population, that maybe we could target those folks early in treatment. So I did find one study from 2017 that is in the Annals of Clinical and Translational Neurology, and they found a couple different things. It's really interesting. They pinned it on 4 different factors. So the first one is how visually dependent you are as a person. So you all know there's some people that are just visual people, right? You've got other people that are kind of verbal people. So what they found is it really depends on how much an individual person relies on vision for their spatial orientation. So some of us are just kind of in our own world. We're very much internal. Other people are different. They are extroverts. They depend on a lot of things in the environment for their personal equilibrium. So that's one factor. The other thing was anxiety. So the more anxious people were, the more worried people were that their symptoms were a sign of an impending stroke, that their symptoms were never going to go away. If they had catastrophic thoughts, nervousness, that was symptom number 2. Number 3 was autonomic arousal. And what this really means is how keyed up did the person's whole central nervous system become when this peripheral nervous system issue was happening in the ear. So you've got the inner ear issue, you start to become, you have the vertigo, you start to feel like your eye movements are getting kind of funny, but then does the whole rest of your body go along for the ride? Does your heart rate start to beat? Do you start to sweat? Really, it's a part of anxiety. Do you basically panic? And the last one, number 4, is really related to what I was saying before, and it's categorized under fear of body sensations, which basically means you become afraid of the thing you're afraid of. The exact same thing happens in panic disorder. At first, people have panic attacks for reasons that are unknown to them, but after a few, the panic starts to become about the panic, and all they're really fearing consciously is having a panic attack in a certain situation. So what this is really teaching us is that something can start off as an inflammation of the vestibular nerve, but over time, if we develop an anxiety about it, that anxiety can actually perpetuate it. So again, this is where the beautiful specialty of neuropsychology comes in, because we cannot artificially separate things that are related to brain and separate things that are related to person and psychology and mood and coping. These are 2 sides of one coin, of course. So one of the questions, of course, is how do we treat it? Well, there was a great paper that just came out this year that looked at the top 4 ways that doctors have gone about treating VN, and they basically ranked them. So the very first one, and this is going way back, is steroids. There's corticosteroids, which are basically manufactured steroids in a lab that are meant to mimic the steroids that our body makes, right? The other one is antiviral therapy. So this is like a cyclovir for the herpes virus. Number 3 is a combination, or 3, not 4. 3 is a combination of the steroids and the antiviral. And the 4th one, which is probably the one we recommend most that people go back and talk to their neurologist about, is vestibular rehab, vestibular rehabilitation. And I'm wondering if any of you who are listening have ever done that. So if you review the scientific literature, what they're going to tell you, this is why you listen, I hope, is you don't have to go do this research now, because I'm going to give you the synopsis, is that the steroids have, like I said, the reason they got on board was we know this is an inflammatory issue, and we know that other inflammatory processes that involve an inflamed nerve, like optic neuritis and multiple sclerosis, a facial nerve palsy, like Bell's palsy, and there's some types of hearing loss that are actually related to a viral issue. We know that steroids basically calm the inflammation. We know that over time the steroids help very much at the beginning, but there's definitely a suggestion that in the long-term clinical recovery, these people aren't necessarily getting a full resolution of their symptoms. When we look at the antiviral agent, the acyclovir, it does not seem that it helps that much. So that one has actually kind of gone out of fashion. Then, of course, combining them, what the research studies have shown is they think it's really the steroids that are actually doing the helping. The next one is vestibular rehab. So what is that? That is a wonderful exercise-based program that is administered by a physical therapist. It's designed to reduce symptoms of vertigo, dizziness, the gaze instability of your eyes, imbalance, falls, all that. And really, It involves good old neuroplasticity. And what I mean by that is you learn over repetitive action to have other parts of your brain compensate for that peripheral nerve disorder. So this is when you learn to use a different body system called proprioception. You can use your somatosensory modalities. You can use other parts of your vision. And basically you learn to substitute for the input that you were used to getting from that inner ear nerve. So it really depends on the health of these other brain areas that we're calling on to take over the job. And this really mostly is brainstem and cerebellum. So if you have problems in those areas, it is going to be harder to succeed in vestibular rehab. There is moderate to strong evidence that vestibular rehab is a safe and effective management. And the idea is it not only reduces symptoms, but it keeps people off the steroids. So unfortunately, when you take oral steroids for a long period of time, you have a higher chance of some not so good things like cataracts, so a clouding of the lens in an eye that requires a surgery, high blood sugar, which can worsen or trigger someone to become diabetic or have worse diabetes, and you increase your risk of many types of infection. So bacterial infection, viral, fungal, all those microorganisms kind of thrive in a steroid environment. If you don't have insurance, if you don't have access to vestibular rehab, the internet is a wealth of information. There are things called gaze stabilization exercises, Cawthorne-Cooksey exercises, and I was going to post a site for you, but honestly there are just hundreds. What I would like you to do is look for a site that isn't trying to sell you something, and something that is associated with a government organization or some type of well-respected scientific organization. There are other drugs that are sometimes used, specifically Meclizine, which is also called Antivert, or Valium. And the goal of these medications is, of course, to help the dizziness not be as strong. It has shown to reduce nausea by a little bit, but the problem is these can be counterproductive because they also affect brain function. And so you can't really do the compensating, but they're often given to people when they're really desperate. They've been in bed for 24 hours and the room won't stop spinning. And so we almost think of them kind of like mercy drugs. You have to put the person out of their misery so that way they can basically be able to participate in the therapies that are going to get them better in the long term. So I hope by listening to this, if you are someone who is experiencing VN, that maybe you feel more validated, you have a little bit more information. Maybe you also know someone who has it and you're not in that brain and body, and so you maybe have more empathy now for what those people go through. It really must be so hard to not feel stable and grounded in your own brain and in your own body. So if you found that this was helpful, I would really appreciate you sharing it. The more people that hear good science-based information about the brain, the better brain community we can build. Thank you guys so much. I will be back with you next week. And remember, this was a topic that was just sent in by somebody who wrote into our inbox. So if there's something that you would like me to talk about and research, I would be more than happy to do so. So either write it down here, send me a message here on Facebook, and I hope all of you celebrating Thanksgiving tomorrow have a wonderful holiday. I look very much forward to having some nice downtime with the family, eating some good food. So I'll see you guys next time. Bye-bye.